Thank you. Okay, thank you for this introduction. Let's start with the next slide, please. Okay, so this is the disclosure for this webinar, which is supported by Edwards Life Science. Next slide. Okay, let's start with some basic facts about heart valve disorder. There's 4 heart valves, 2 on the right side, the tricuspid, the pulmonary, and 2 on the left side, the mitral and the aortic valve. So basically we know that disease are either congenital, meaning that they are developmental abnormalities, or they can be acquired during life. The processes that affect heart valves are either stenotic. It means that it impedes the opening of one or more than one valve, and or a leaky process, meaning that there is a regurgitation process, is the other presentation. In order of frequency, the valves that are involved most often, the first one is the aortic valve, which is between the left ventricle and the aorta, the large vessel that distributes the blood flow throughout the body. The mitral valve between the left atrium and the left ventricle, the tricuspid on the right side, and the pulmonary between the pulmonary artery and the right ventricle. So next. So we'll go through briefly clinical presentation. Patients can be either asymptomatic or symptomatic. For those who are symptomatic, basically a physical exam with a heart murmur raises suspicion for a heart valve disorder. Also, during a routine exam for echo Doppler for another indication can detect a heart valve condition, as well for CT scan, which can detect calcification in one of the heart valve, which is obviously an abnormal sign. For those who are symptomatic, the most frequent symptom is shortness of breath. Some patients, even without coronary artery disease, may experience chest pain or angina. Other patients may have syncope or the transient loss of consciousness. Palpitations, fatigue, or loss of energy are other symptoms. Next slide. So let's go through the most common and frequent congenital abnormality of the heart, which is the bicuspid aortic valve, which is present in about 1% of the general population. So it is a valve with 2 cusps instead of 3. So normally there is 3 cusps, and the most common type of bicuspid aortic valve is a fusion between 2 cusps. So it gives 2 cusps instead, and it increases the risk for different pathologic conditions. Calcific aortic valve disease, which is the abnormal deposition of calcium on the aortic valve. Aortic regurgitation, which is a leaky aortic valve. Aortopathy, which is the dilation of the aortic root, and or descending aorta are other conditions that are prevalent in patients with a bicuspid aortic valve. And the presence of a bicuspid aortic valve increases the risk of infective process called endocarditis. Next. So the natural history is that most patients with a bicuspid aortic valve will seek medical attention for a complication. For instance, in this study of 20 years follow-up, a third of the patients did seek medical attention for a complication needing a surgical or a medical treatment. So patients with a bicuspid aortic valve need a regular follow-up for their condition. Next. So the most prevalent heart valve disease, which affects both the bicuspid and tricuspid valve, is calcific aortic valve disease. So it is the most frequent heart valve disease. It is related to a progressive calcification of the aortic valve. There is on the right-hand panel a valve which is heavily calcified. A section through the valve shows the calcific nodules typical of this disorder and the thickening of the leaflets. And once it is severe, most of the patients will become symptomatic. Next. So the prevalence on this graph is illustrated on the y-axis. On the x-axis is the age. And we know that age is by far the most important risk factor for calcific AS. And the inflection point is about 65 years, where there is a sharp rise in the prevalence of that disorder. And estimates are that between 2 and 8% of the elderly populations do have a calcific aortic valve stenosis. Next. So calcific AS, once severe, portends a poor prognosis as shown here, as the vast majority of patients will experience an event during a 5-year period. So it is severe. It is obviously a condition that needs a treatment. So if left untreated, the prognosis is poor. Next slide. So why it is that so? It is related to the fact that owing to the presence of a stenotic process at the level of the aortic valve, there is a pressure overload into the left ventricle cavity. So the heart responds to this by an hypertrophic response. It means that the cardiomyocyte, the cells of the left ventricle, get larger, and they secrete extracellular matrix in response to this. And a maladaptive response to this is to lead to a fibrotic deposition within the left ventricle. So eventually, it leads to a heart failure, and then it portends to a poor prognosis. Next. So the risk factors, age, as we've seen, is the most important one, but other risk factors that are shared with other cardiovascular diseases are male gender, dyslipidemia, including lipoprotein little a, on which we'll have some discussion, hypertension, smoking, and low-density lipoprotein. So those are classical risk factors associated with other cardiovascular pathologies as well. Next slide. On the top of this, we know that there is a clustering of heart valve disease, including calcific aortic valve disease, as in this work in the western part of France. There is a clustering of cases in some extended families. So there is a transmission in some families of calcific AS, and also for some cases of mitral regurgitation. Next slide. In the general population, there are also risk factors related to the genetics, and this has been highlighted in genome-wide association studies where variants in a gene called LPA, which encodes for a lipoprotein little a, is causally associated with calcific aortic valve disease. We know that the level of this lipoprotein, which is like a low-density lipoprotein, but to which an apolipoprotein little a is added to the particle, is determining the level of those particles in circulation. And about 25% of the population do have genetically determined elevated level of LP-A, which is a risk factor for the development of calcific aortic stenosis. Next. The process whereby, at least in part, this lipoprotein induces calcific AS is through the fact that it transports enzyme, including one which is called autotaxin. It produced from the lipoprotein bioactive lipids, which acts as mediator that promote inflammation and calcification of aortic valve cells. Next. Another gene that has been recently discovered is within the PALM-D gene. So this risk variant is highly prevalent, at least in population from European descent. About 50% of these population are carriers of the risk allele. It decreases the expression of that gene within the aortic valve, increases the risk, and it explains about 12% of the cases among the general population. So a significant genetic risk factor. Next. So if we go to the clinical evaluation of patients with heart valve disease, the first step is obviously the medical history, clinical exam. If there is a suspicion of a heart valve disease, echo Doppler is by far the first modality to use and the modality of choice. It allows three things. First, it evaluates the function. It measures gradients through the valves. It also allows the evaluation of the pump function of the heart and also gives images that allows the physician to detect the presence of nodules of calcium, a thickening, or the anatomy that is present within the heart. In some cases where there is what we call the low gradient, low flow aortic stenosis, a CT scan can be used to document the amount of calcium. So this determines quite precisely the amount of calcium and can be used to assess the severity of calcific AS. And also in these selected cases, MRI can be used to evaluate the fibrotic pattern within the left ventricle. Next. So not going into detail about this, but a brief word about the treatment of calcific AS. Just to mention, once the disease is severe, most of the patients do have symptoms. And if there is no contraindication, a surgical intervention is needed to replace the aortic valve. In selected cases who are deemed at risk, a transcatheter approach or TAVR can be used to treat those patients. Next. So treatment involves basically two types of replacement, mechanical or tissue valve. Mechanical valve mandates a lifelong anticoagulation, whereas tissue valve do not. However, tissue valve are prone to degenerative process. Therefore, the selection of either a mechanical or tissue valve relies on different factors, such as the age of the patient, the different risk factors, life expectancy, and obviously, after informed consent, the patient's choice. Next slide. So a brief word about TAVR. TAVR is the insertion of a valve through usually a groin incision through the femoral artery. A catheter is passed through the aorta, guided through the aortic valve, and following echo guidance, the valve is deployed in place, and it is a tissue valve. So it is a less invasive procedure that can be used, as we mentioned, in selected patients. Next. A brief word about the mitral valve. In North America, the most frequent pathology of the mitral valve is a mitral valve prolapse or floppy mitral valve. It is, in fact, an excess of tissue on the mitral valve. And most often, the posterior leaflet, the anterior leaflet is usually involved, but to a lesser degree. And the posterior part of the leaflet has an excess amount of tissue. So once there is an indication of treatment, the surgical repair is certainly the best option. It consists into the resection of the diseased part of the valve, the repair, and the insertion of a ring around the repair. This has the advantage to keep the native tissue and to avoid the replacement with a mechanical prosthesis. Next. So in conclusion, we've seen that heart valve disease can be either congenital, acquired. Some are related to genetic risk factors in families and also in the general population. Lifestyle risk factors do play a role, at least in the development of calcific aortic valve disease. The obesogenic lifestyle is certainly a risk factor. Therefore, preventive measure in the general population could decrease the burden of calcific AS. Detection measures are easy with echo, which is a non-invasive procedure. And treatment modalities so far are either surgical or by transcatheter approach. However, ongoing research suggests that some treatments, medical treatment, could be developed in the next following years in order to treat or to prevent the development of some heart valve disease. Thank you.
Thank you, Patrick. And now over to you, Craig.
Okay, thank you, Kristen. Yeah, so that was a fantastic overview from Dr. Mathieu, and I'll pick up from there and tell you a little bit about some of the emerging research that gets to some of the points that that Patrick highlighted about the need for drugs and alternative treatments. Next slide. So I've highlighted 4 what I call hot topics in heart valve research. These are really unmet needs within the field, and where areas in which there is a lot of active research and some emerging promising results coming from them. And I just wanted to briefly highlight some of those. These again are things that aren't available clinically now, but you know, hopefully and very well could be in the near future. So first, and as you can see from the list here, I'll talk a little bit about, can we identify drugs or medical treatments for heart valve disease? Can we detect valve disease earlier than what we can do now? Emerging evidence suggests valve disease is different in men and women, and what are the implications there? And then the final one is something, an area we work in, and can, instead of replacing diseased valves with mechanical or tissue valves, can we actually replace them with a living replacement valve? Next slide. So the first question is, can we find a drug or a medical treatment to stop or slow aortic valve disease? And as Dr. Mathieu mentioned at the end, that this is a very active area of research. There currently isn't a medical treatment. The only treatment for valve disease currently is replacement. And so there's a lot of interest in identifying targets, therapeutic targets, to prevent or slow valve disease so that surgery and valve replacement isn't necessary. The diagram you see there is not, I'm not going to go over that, but basically there are 3 main processes that are thought to occur. The details are in the diagram, but if you look at the titles at the top, Dr. Mathieu mentioned lipids and lipoprotein little a being an important component of valve pathology and the initiation of disease. So lipid infiltration is a big component of the disease. This can promote and lead to inflammation within the heart valve, and then ultimately the valve becomes scarred or fibrotic or scarred, and has calcium deposition, which results in its hardening and dysfunction. And so there's a lot of, and all those molecules that you see labeled in the slide there are all different targets that have been identified to play a role in the disease process and potentially could be therapeutic targets, although currently we don't have a drug that has been shown effective to prevent or slow this process. But certainly Dr. Mathieu's lab has done a lot of excellent work on looking at the role of lipids and their influence on inflammation leading to the scarring and hardening. My lab has identified some molecules that play a role in preventing scarring. And so there's a lot of, and these are just 2 examples of many research groups attempting to identify the drugs. Related to that, and on this slide now, is can we diagnose valve disease earlier? There's some thought that perhaps once the valve gets to the scarred and hardened stage, that it may be too late to intervene, and maybe a drug will not be effective at that stage because the valve is already severely dysfunctional and disrupted, and the matrix, the tissue that makes up the valve, is sort of past the point of no return. That may not be the case. Maybe some of that can be reversed, but certainly if we could identify the valves that are on their way to becoming scarred and hardened earlier, there may be opportunity for some other therapies to be effective. And so next slide. Dr. Mathieu mentions echo and other methods to look for whether a heart valve is diseased, but again, these typically will identify valves that are further along in a later stage of disease. There's some promising techniques, for example, molecular imaging, which I'm showing here, that are emerging, in which not only can you get anatomical information by CT, for example, to know what the valve looks like, but you can also use imaging methods such as positron emission tomography or PET imaging to look at, are certain molecules being detected in the valve, and these molecules may be indicative of early inflammation, early mineralization, and other disease processes that occur before the valve is too far gone. And so the pictures here you see show on the left panels, from the top to bottom is an early valve disease case, and then increasingly severity of valve disease as you move down. And the left panel shows what it would show on CT. You can see those white spots indicate areas of calcification. The middle panels show what the PET imaging would show, and this is now detecting a molecule that is imaged and binds to much earlier stages of calcification. So it's predicting where calcification will occur. And if you look at the rightmost panel, which shows what's happened 1 year later, you can see the areas that were highlighted with the hot yellow and red colors by PET imaging have now become calcified under CT. They've become white calcified areas. So this is promising in that perhaps PET imaging, which is looking again at the molecular level, perhaps this could be predictive of valves that would go on to form more severe disease. And so this is one technology that's being developed and could detect perhaps lots of those early processes that we think are occurring to cause valve disease. Next slide. The other question that's come up, and this is work again that's come from Dr. Mathieu's the center where he works, from one of the best centers for heart valve disease in the world, really, is valve disease different in men and women? To this point, physicians have treated valve disease as just one type of disease, but I think more and more we're realizing that the valve disease is very different from person to person. It's very heterogeneous, and what is emerging is sort of the first level of stratification is maybe there's a sex dependency. And to date, this really hasn't received the attention it has, despite the fact that women die frequently from heart disease. They're much more likely to get heart disease than breast cancer, and yet much of research is focused on men. Next slide. And the Heart and Stroke really has taken this on as a mission. In this year's report, CEO Yves Savoy really, is a call to arms that women are under-researched, underdiagnosed, undertreated, and we really need to change this. So next slide. And so is valve disease different in men and women? And this again was work that has come again out of Dr. Mathieu's center. These are valve image pictures of valves cut out at surgery from our center. And you can see they are different. So on the top is a male valve. The pink staining you see there in the valve is all calcification. And you can see the male valve has a lot of calcification in the valve. In contrast, the female valve shown at the bottom has a lot of scarring and doesn't have the same extent of calcification. These two, the patients with these valves, they showed the same symptoms. Their valve was same extent of dysfunction in their valve, but clearly the men and women are having very different disease processes resulting in that dysfunction. Next slide. But we don't know why. We don't know the cause for these differences. And then the big question then, what are the implications for treatment? If we are to find drugs to prevent valve disease or slow valve disease, perhaps this implies that men will need a different drug because they have a different disease mechanism than women. This is very much an open question, just now being recognized in the field, and I think will be an area of lots of advances in the very near future. Next slide. The last hot research area that I want to highlight is this idea that can we do better than what we're doing with our current valve replacements? So in the absence of a drug, valve replacement therapy is the only option, and mechanical and biological replacements, as you'll hear from our patients, our panelists later, they work exceptionally well. But for certain populations, and particularly young children who are born with a congenital defect, they don't have any good options because they really need a replacement valve that can grow with the child. And currently, neither of the valves that are available provide that opportunity. These valves also have limited lifespans in the case of the tissue valves and will have to be replaced. The mechanical valves require the patient to be on blood thinners. So there are certain limitations even with what we have currently. So many people, many researchers, and ourselves included, have started to dream about what if instead of using a synthetic valve that's made of plastic and metal and animal tissue, what if instead we could make a replacement valve that could actually grow and it was a living replacement valve. Next slide. So this is one example. This has come from a group in Switzerland, Simon Horstrup's group. This was published just earlier this year. And what you're seeing on is an off-the-shelf living replacement heart valve. So what they've done in this case, in that panel A, you can see the heart valve there. It's an aortic heart valve. It's been grown in the lab using biomaterials and cells extracted from a sheep in this case. And they grew the tissue in the shape of a heart valve. And then to make it more compatible with a different, they took the cells from one sheep, and then to make it compatible with another sheep, they actually removed the cells. And so what's left is just the tissue that the cells have formed, and it looks like a heart valve. And you can see in the bottom right, it's functioning like a heart valve. This is a top-down view, and you can see it opening as the blood is being pushed out, and then closing and sealing nicely to prevent backflow of blood. So the potential here is that these valves could be grown in the lab. They could then be stored. You could have different sizes. And then when a patient needs a valve replacement, instead of getting a mechanical or tissue valve, they now get an engineered valve, where this is now a living tissue. And the idea is that cells from the patient's body would then start to populate or grow into this tissue and help maintain the tissue long term. Now, this is still very early stage work. In this study, which is the best to date, they were able to show that it continued to function in a sheep for 1 year. And that 1 year it was still functioning well. But this has yet to be shown to work in a human. And there still exists some challenges to this approach. Next slide. Our group is doing something similar, and in our case, we're interested in can we come up with living heart valves for children born with defects, congenital defects in their valve. So one example of that are defective pulmonary valves that can occur in children who have a condition called tetralogy of Fallot. The idea here is that we could diagnose, or that clinicians could diagnose that the baby has a defective valve in utero. And so when the baby's born, we can actually take, our strategy is to take the umbilical cord from the baby. This is a rich source of stem cells, and those stem cells are the baby's own cells. And so our idea then is to take those stem cells and put them on a biomaterial that is compatible with the body. And next slide, or next click, and put those onto the material where they will start growing tissue. And because this is the baby's own cells, the tissue that's produced will be the baby's own tissue. Now, the tissues that we form aren't strong enough to function as valve tissue. So one thing we can do in my lab, for example, is we can exercise the tissue. So much like when you go to the gym and lift weights and your muscles get bigger and stronger, we can exercise the tissues in the lab to make them stronger and more valve-like. And then once we have a sheet of tissue, we could, one option is to hand it off to a surgeon, and then they can do this really intricate origami method, for example, to form a complete replacement valve, or maybe they could just use the tissue sheet as a repair material. So the idea here is that, and I didn't mention, the biomaterial itself degrades away into harmless byproducts. So the idea here is that what we're left with is now a tissue that's formed from the baby's cells. It's completely the baby's tissue, and now is a living replacement valve that, once implanted back in the heart, the idea would be that this would have now the capacity to grow with the baby, grow with the baby's heart, and repair itself and adjust to the new demands that the baby puts on his or her heart as she or he grows. So this is our approach. We're actively working in this area, but again, these are not available currently, and I think we'll still probably a few years out before we see these in patients. Next slide. So that's just a brief summary of some of the promising progress that's being made in heart valve research in terms of new targets for therapies, new ways to diagnose, new understanding of why disease occurs, including differences in men and women, and new surgical treatments. But I think hopefully what you came away with is there's a lot of promise, but really this fundamental and translational research on the causes of heart valve disease are really essential to keep this field moving forward and provide new opportunities for patients. Thank you.
Thanks, Craig. So now to introduce our next two speakers. Ms. Sandra Thornton has, for over 30 years, provided large and small organizations with leadership in defining and developing successful communication strategies. Sandra is also a passionate volunteer. From 1999 to 2006, she served on the Heart and Stroke Foundation Board of Directors in Alberta, including 2 years as board president. Things changed for Sandra in 2011 when her cardiologist told her that unless she had surgery to replace a valve, she would only live for another year or two. Today, Sandra is actively creating more moments in her life on a country acreage where she enjoys an active lifestyle and continues to volunteer at the national level with Heart and Stroke, most recently as the co-chair of Heart and Stroke's Heart Failure Council. And Lori Constable-Smolcic is a nurse in cardiac surgery, where she works as part of the database and triage team. She co-directs the Beat Retreat, the only adult congenital cardiac clinic in Canada, or camp, in Canada, which is volunteer-based and organized by individuals born with heart disease. She's also recently served as a volunteer on Heart and Stroke Structural Heart Disease Council. So now I'll give it over to you, Sandra.
Thank you. Hello, everyone. As you can see from this picture, I've always been a very active person. I like to do all kinds of sports and activities and considered myself very healthy. But in December of 2004, my life changed. Just after turning 51, I had a 90% blockage of the left anterior descending artery. And I had an angioplasty and then reblocked again 3 months later in the same place and had another angioplasty. But eventually I turned the corner and returned again to my active life. Next slide, please. So one of the things that I learned during the time that I ran into some problems with my cardiovascular system was that I had also a problem with my aortic valve. I had aortic stenosis and aortic regurgitation. The interesting thing is I'd had a heart murmur all my life, and every time I went to a new doctor, they would always comment about my heart murmur, and I'd say, well, I've always had it. I'm fine. So I learned at that point that I actually was born with a bicuspid aortic valve, as was described earlier by Dr. Mathieu. That explained the lifelong heart murmur. So most people, I understand, with bicuspid aortic valves live unaware of the situation until at some point when they start to become symptomatic and when the valve is no longer functioning adequately. I was told that I would have to have my valve replaced at some point, but they couldn't predict when, and that I would just be monitored because at that point I was asymptomatic. So I had an annual echocardiogram and checkup with my cardiologist, and for 7 years everything was fine with no further blockages or deterioration. But then I started having symptoms, and I first noticed that I wasn't feeling good, and that was in the spring of 2011. By summer, I was getting winded whenever I exerted myself, especially going up hills or stairs. On 2 occasions that summer, I found myself gasping for air and my chest hurt so bad I thought I was going to have to call 911. On vacation in Italy, I climbed the stairs to see the view off the Amalfi coast. And if you've ever been to Amalfi, you know that the town is built on steep cliffs with incredible views. And to get anywhere, you have to climb stairs, and lots of them. I was very breathless, and we rested at the top for quite a while until I got my breath back and we started down. And I passed out on the way down the stairs. And then I had a similar experience about a month later, where one moment I was upright and the next thing I knew I was face first on the ground. And I was at the dump of all places, so that was rather disconcerting. Next slide, please. So it got to the point where even walking my dog winded me. In October that year, I had my annual appointment with my cardiologist, and I had called and said, you know, I'm getting concerned. Well, I had some tests, and he said it's time for surgery. I asked what sort of timeline we were looking at, thinking he might say, oh, within the next 6 months. But to my surprise, he said within weeks. We met with the surgeon, my husband and I, just days later, and I was pretty surprised and shocked when he told me that if I didn't have the aortic valve replacement, I really only had 1 or 2 years to live. I chose life, and within just a few short weeks, I was in surgery. As was described earlier, I was given the choices regarding the type of valve, whether I would have mechanical or tissue. And you've heard some of the pros and cons. My choice was to go with a tissue valve. Next slide, please. So this is me on November 21st, 2011, after open heart surgery. The surgery was about 4 hours, and during that time I was on the heart-lung machine for 87 minutes, just under an hour and a half. Well, my own heart had been stopped and was being worked on. They enlarged the aorta and put in the replacement valve. The next slide that I'm going to show you shows a photo of my scar just in the first week. I'm proud of it, and I don't think the photo is offensive in any way, but just giving you a warning in case you might find it a little bit graphic. Next slide. When I awoke in cardiac intensive care, I was surrounded by my family, and after a week in hospital and a gradual recovery of about 7 weeks at home, I regained my energy for life. And although the experience of open heart surgery is not easy, I feel it was an incredible gift for which I'll forever be grateful. It's probably one of the most profound experiences I've been through, but here I am today. I will have to have my valve replaced again because I chose the tissue valve. But with continued advances in medicine, there's a good chance that when I have to have my valve replaced, it will be done through the less invasive surgery, the TAVR, which is more like having an angioplasty. Next slide. So it's been 7 years since my valve replacement. I have an annual checkup with my cardiologist who says I'm really boring, which I think is great. I continue to lead a very active life. I hike, I work out, I golf, I skate, I bike ride, and more. And here I am on the top of a small mountain in BC last summer. I'm able to enjoy my family and my 6 beautiful grandchildren and life on my rural property, and it's all thanks to my valve replacement. Over to you, Laurie.
Oh, who's muted?
You're on, Laurie.
Oh, thank you. So I'm Laurie Constable-Smolcic. As you can see the slides, you're lovely. I was born with 3 holes in the heart and a cleft mitral valve, incomplete cleft mitral valve. The only thing that means is that my mitral valve, one of the leaflets wasn't attached to one of the tissues that it was supposed to be. So it sort of was flapping in the wind, almost like a prolapse, but not exactly. So when I was born in September of '72, they didn't like to do surgery right away on children if they didn't have to. So they took me over to Toronto General, and they debated if they were gonna, they took me over to Sick Kids, and they debated if they were gonna do surgery or not, because I was in heart failure. What they ended up doing was just get me as stable as possible, and they tried to keep me from having surgery until older, as again because they wanted to see if the heart would at least grow or kind of not fix itself but help itself in a way. And so from the time I was born until I was 9 years old, I was in and out of the hospital. Always in and out of heart failure, always with pneumonia. My second home was Hospital for Sick Children's. And then finally, when I turned 9 years old, they told my mom that I was going to have surgery. But between that, during school, while I was in school, I was not allowed to run. I was not allowed to play. I had to sit in the corner during gym. The school was scared. Even the doctors were scared because they didn't know what really was going to be the outcome, or if I exercised, what would happen, or that. So I got to be not as active in school or with my doctors, but my mom, who was born with heart problems, also always said, hey, if you think you can do it, do it. So when I was outside of school and everything else, I would try to run and I would try to play, and I learned my limitations. But then again, as I said, when I turned 9, they told my mom I needed the heart surgery, my very first one. I went in and they closed all 3 holes, and they repaired my mitral valve. With the mitral valve repair, they put a Dacron patch over it, which is just to try to keep the valve from needing from replaced again due to growth. After the first surgery, I was pretty well. The nurses said I was in the playroom pretty well almost right away after I woke up. All I wanted to do was go play. And I didn't feel anything different. I was just doing what I was doing. And everything was going well until I was in college at that time. I was doing an environmental diploma, and I started feeling tired all the time again. I couldn't keep my eyes open. I was short of breath again, all over the place. I felt horrible. And I went to my cardiologist, and my cardiologist basically said, oh, it's because you're in school, you're a woman, it's your hormones. And I was frustrated then because I knew there was something wrong. So I told them, please do a heart cath. So they did a heart cath, and they told me, okay, you can't go home, Lori. You have a couple things wrong that we need to fix again, do open heart surgery. So at 23, I had my second open heart surgery, and it was for another valve repair. They had to repair my mitral valve again, and they also had to do a subaortic stenosis repair. And what they found with my type of condition over the years, a complication is getting surgery as a child, is that subaortic stenosis can be one of the complications. So I got that fixed. But after I got that fixed, I started having a lot of arrhythmias. I was going in and out of AFib, in and out of torsades, in and out of everything you can just imagine. But the main one was atrial fibrillation, where the ventricle's just going wonky. And so they put me on a whole bunch of heart meds that I really never had to be on before. I was on maybe 3 meds during most of my life, and now I was going on like 6, 7 of them. And then they tried an ablation where they put the heart catheter up into the heart, and they would burn the areas that were causing the atrial fib. They were able to get a couple of the pathways, but they knew they hadn't got them all, and so I could still go in and out of AFib. Now, throughout all this, again, off and on, I would be great. I was able to go back to school. I did my nursing diploma, started actually working with people that looked after me from the hospital for sick kids, who remembered me as a child, which was hilarious, still is. And then throughout that time, once I turned 30, again, I started having so short of breath. I was losing weight nonstop. I was getting cramps bilaterally in both legs. I just couldn't even walk without needing to sit down. And I said, that's not me. That's not right. There's something wrong. So I went to the hospital, and my cardiologist was like, you need a mitral valve replacement. The valve has finally blown. And so when I was 30 years old, I got my mechanical mitral valve replacement. They did not give me a choice if I wanted mechanical or tissue. I was told I was getting a tissue valve if I wanted it. They told me I was getting a mechanical mitral valve if I liked it or not, because they, for my age and for my, just me being me, they just wanted me to have a mechanical mitral valve. So at 30, I got it, and it was a rough go for the first couple months. I was back in and out of heart failure. I was back in and out of all my arrhythmias, and I stayed in AFib after surgery. So they eventually had to cardiovert me, and I've had multiple cardioversions after my second heart surgery. And this time when they cardioverted me, my heart rhythm changed, and I needed to get a pacemaker with a defibrillator for my long QT syndrome. I got the defibrillator and then ever since I've just have been going in and out, just getting checked, interrogated. Anyone who has a pacemaker or defibrillator knows you get interrogated. You go get checked out. So I'm ending up now on my 7th defibrillator since 2004, just because I am 99% paced in the atrium and 100% paced in the ventricle. I do still have 1% arrhythmias, and it's funny, but my heart does try to give itself a rhythm once in a while. But exercise is really horrible for me, even sometimes walking, because my pacemaker is not rate response. So when I walk faster or try to bike or try to even like exercise, my rate will not go up, just because my heart cannot handle doing it unless it goes in arrhythmia. But overall, as you can tell by the pictures, I still try to do everything I want to do. I try to, be as healthy as I can live. I don't technically nurse or floor nurse anymore. I'm now in the cardiac surgery database. I keep my nursing license because my work still gives me projects to do, and I help co-create and co-direct the Beat Retreat, which is the only congenital cardiac camp in Canada. We've had people from the States come, and it's a 4-day retreat for people to come learn. Other patients, congenital cardiac patients, come learn, be with each other, because we never have had that support. So we all try to be there to support each other. And I think that's about it. I hope that's okay, Sandra. And Christian?
Yes, great. Thank you, Lori. We have time for questions now, and we've received a number already through the GoToWebinar platform. So I'll put these to you, our speakers, right now. And I guess to start off, Sandra, you raised the issue of a heart murmur. We have a question come in from BC. And Patrick, I wonder if you could talk to this. What does a heart murmur tell us, and how does that maybe relate to heart valve disease?
Yeah, well, with regard to the question, it's Patrick. Well, a heart murmur can be related to heart valve disease, but also to other conditions. So there's different types of murmur. There's a murmur that are related to an aortic stenosis or different pathologies. For instance, a murmur for a mitral regurgitation is different from a murmur from the aortic valve, and so on. So there is different types of murmur, but your physician following examination will have the type of murmur. Knowing the type of murmur will prescribe different exam that are appropriate to diagnose your condition. but not every murmur is related to necessarily a significant heart valve pathology.
Thanks, Patrick. Now, Lori and Sandra, and Patrick too afterwards, we had a question come in, again, asking about symptoms, and I think this is really important for people to hear. So I wonder if you can quickly describe some of the symptoms that you've experienced over the course of your conditions evolving, and Patrick, some of the symptoms that people should be looking out for. So Lori, maybe you first.
Yeah, for me, what always ended up happening is I would lose weight and I would get more short of breath than normal. So even when I was just walking a couple steps, I would be very short of breath. I couldn't catch my breath. It at first felt like, oh, I had exercised too much, yet I only walked. Those were basically the most two for me, and just fatigue. Like I could sleep maybe 23 and a half out of 24 hours a day if I really wanted to.
Sandra, anything to add?
Yeah, in my case, the symptoms came slowly over time, and so I don't think that initially I was aware of just how tired I was all the time and how I didn't have the energy that I used to have. That became more apparent to me after I had the valve replaced, and I realized, holy cow, I really wasn't feeling well for some time. But once things escalated, I had, I think, all of the symptoms that were discussed earlier by Dr. Mathieu. I had the fatigue, I had the breathlessness or short of breath, I had the fainting, I had some chest pain. I think I was probably pretty textbook in my symptoms. But I think that probably the difficult thing is if you're not diagnosed and maybe you're in the early stages, you won't necessarily recognize what's going on. I mean, I used to just rationalize and say, well, I've been very busy, that's why I'm so tired.
Yeah.
Patrick, anything to add? Thanks.
Well, I think that Sandra's and Laurie's, their symptoms are typical of patients having a heart valve condition. But just to mention that those symptoms are not specific to heart valve condition. They might be related to different heart condition or lung conditions. So basically, recommendations will be that if you feel that that anything has changed recently in your condition, shortness of breath, palpitations, or you experience fatigue, which is abnormal, obviously those are signs that you should probably consult your physician, and in order to detect earlier heart valve conditions. And also it is worth highlighting that if we can detect early heart valve diseases, though we don't have treatment so far to treat early valve disorders, it is important to make the diagnosis early in order to have a good follow-up of patients having a heart condition related to a heart disease with valve that are implicated. So that will allow the physician to eventually propose a treatment if there is any surgical indication, for instance. So it is appropriate to consult early.
Thanks, Patrick. And I think that's actually a really good message to end on. I wanted to flag as a final note for everyone that if you are living with heart disease or stroke, or if you know someone who is, or if you're caring for someone who is, we encourage you to check out our members-only Facebook groups, one for survivors and one for those who care for them. We also encourage you to check out our e-registry if you'd like to receive more materials. and specifically about heart valve disease or valvular heart disease, please check out or consider looking at the 2 pages that we have on the Heart and Stroke website, one dedicated to valvular heart disease and the other to treatments, including surgery and other procedures for heart valve disease. And as always, we're here to answer questions. If you have any following the session, you can email us at this email address posted below. I want to thank our speakers today for taking the time. Lori, Sandra, Patrick, and Craig, we are grateful for sharing your expertise with us. And I want to thank everyone who logged in. We thank you for participating in the webinar, and we wish you a great day.
Thank you.
Thank you.
Thank you.
Thank you. Goodbye.
Bye.
Are we too early? No. Okay. Just
sorry, I'm doing a webinar for the heart and stroke today.